Welcome back to Clinical Problem Solving. This is Module 3, and we're going to do a lot of fun work today. Here's where all of the building blocks will come together, and you'll learn how to make a wonderfully prioritized differential diagnosis list that will guide you easily to select the right testing and hopefully the right treatment for our patients. Again, I acknowledge my collaborators and present for you just a brief review of Modules 1 and 2, which I'm sure you'll recognize because you've done such a good job on the homework. We talked in Module 1 about disease-based illness scripts. These are the foundation of knowledge in expert clinical problem solvers and include always in every disease-based script a statement of epidemiology, who gets it, time course, how does the disease present with respect to time, what are the classic signs and symptoms in the clinical presentation, and what are the mechanisms of action that led to the particular disease in question. We talked about the importance of compare and contrast thinking, recognizing it's not sufficient to understand diseases in isolation. They have to be understood as they relate to other diseases that might cause the common presentations your patients arrive with. And in this case, it was the presentation of pharyngitis that our patient Jeremy had. In week 2, we talked about different clinical problem-solving strategies, starting with hypothesis testing, which is the linking of a single symptom to a long differential diagnosis list, known to be effective in use by novices and also in ultimate clinical problem-solving failures by experts, but overall intellectually taxing and problematic to use on a regular basis. Forward thinking used better problem representation through the skill of processing and a series of nodes of branch chain algorithms so that we could narrow our differential diagnosis before arriving at the right diagnosis. And pattern recognition, where we instantly recognize that all or nearly all elements of a given disease's illness script were present in the patient in front of us. We spent time both last week and on the homework in processing, translating lay language into more abstract and descriptive medical terminology to facilitate activation of memory stores, allow easier seeking of information in medical resources, support compare and contrast thinking, and increase the efficiency and precision of diagnosis. Forward thinking was illustrated, as was pattern recognition. Ultimately achieving what we want before we start our differential diagnosis is a good, robust problem representation. So in Module 3, we're going to start from processing, develop a process problem list, and then use that process problem list to create a problem representation which we'll call the patient illness script. We're then going to use that patient illness script to prioritize a differential diagnosis and demonstrate how that prioritized differential diagnosis can be used to choose and interpret the right tests in a pre-test probability way. So let's turn our attention to the development of a patient illness script. To hone our diagnostic skills, we need to first obtain information from the patient, enough information for us to construct a good problem representation. And the way we do that is to take that information from the patient, compose a problem list of the patient's issues, process that list to increase its impact and specificity in establishing a diagnosis, and create a problem representation that facilitates comparison with disease illness scripts. The goal of the patient illness script is to provide the shortest, richest description of the patient's problem, and to do so attending to cognitive loads and biases. Now, cognitive loads is an interesting phenomena. It's really recognized now that in this era of instant data and information technology, oftentimes our brains are overloaded by too much information as we try to multitask or as we just try and juggle all of the data that's available in the environment. And human beings, despite all the technology at our hands, as we're paying attention to things, can really only attend to about a list of 7 plus or minus 3 pieces of information. That's why our phone numbers, for example, are 7 digits long, or 7 plus 3 if you include the area code, as well as our social security number. In essence, what we're talking about is our working memory, and we have to pay attention to ensuring that we give ourselves the right amount of information to pay attention to, but not too much. So short becomes important, but with short has to be rich. It can't be sparse. And biases are also important. Biases are those mental models we form based on our past experiences that are triggered sometimes by the language that we use. So as we think about ways in which we can make mistakes in diagnoses, we have to be attentive to words or phrases that bias us in ways that we don't find functional. Another goal of the patient illness script is to prioritize the most sensitive and specific information. And also importantly, to eliminate or de-emphasize less relevant or non-specific symptoms. This information may be collected for the patient and may not be lost. It's just not carried front and center. So we'll talk about where we put this in our view and our attention to make sure that we don't forget it, but that it doesn't clutter our thinking as we're trying to solve the problem at hand. So we're going to begin to use the term patient illness script to describe a problem representation. And we're going to do so because the way we prioritize our differential diagnoses when we get to that step is by comparing the patient's problem representation to a disease illness script. And so we have taken the leap to say we're developing a patient illness script that will be matching. And the elements of the illness script for the patient are very similar to the elements of the illness script for a disease. There'll be an epidemiology statement, and that will be a description of what we think as clinicians are the most important demographic feature, exposures, or past history relevant to the patient's current chief complaint. A statement about the time course of the patient's illness, a statement about the signs and symptoms that we think are most important, to as high a level of specificity as possible. And then important medical history that's not otherwise included or relevant to the current acute complaint. So recall the elements of our disease illness script and look at the elements of our patient's illness script, and you can see they're almost identical. All we don't see, because it's unique to the patient and not to the disease, is past medical history that's not relevant to the acute complaint. Any past medical history relevant to the acute complaint would go into epidemiology as a risk or an exposure. So in epidemiology, what things should we include in the patient's illness script? What's in, what's out? Well, first off, as a general principle, we only want to include those elements of epidemiology that are relevant to the existing case. So we should include exposures of relevance. Any drugs the patient is taking, any habits they have, smoking, exercise, alcohol, toxins they might have been exposed to, and medications they're taking that might be relevant to the symptom that they are presenting with. If it's not relevant to the symptom they're presenting with, we'll put it in another aspect of the illness script, not in epidemiology. We should also include past medical history that is relevant as a risk or a predisposing factor for this chief complaint. And we'll talk on the next slide about the judgment involved in that. Sometimes this can be a judgment call or a stylistic thing, but you'll get the general sense when I show you an illustration on the next page. What we generally recommend you don't include are comments about race or ethnicity, because this actually may precipitate bias elements, and it turns out they are not that helpful in terms of identifying differential diagnoses, with a very, very few exceptions. Should make comments about socioeconomic status, which might, of course, be relevant to the patient's ultimate treatment, but should not influence necessarily your differential diagnosis. And you shouldn't include elements of the physical exam, for instance, a description that the patient is obese, because that, again, does not generally help in the differential diagnosis over and above other disease elements they might have, and often may predispose people to biased thinking that they're unconsciously aware of. Now, whenever you make decisions in the course of caring for patients about problem representations or differential diagnosis, there will be judgment calls, and these decisions should be made on a presentation-by-presentation basis, dependent on the patient's symptoms. So, for example, when trying to decide whether the patient's past medical history is included in epidemiology or listed as other relevant history, it depends to a large extent on the type of symptom they're presenting with and the diseases that they have. So someone with a complex history of high blood pressure, diabetes, dyslipidemia, nephrolithiasis, and onychomycosis presenting with a complaint of chest pain, I would argue that you include the high blood pressure, diabetes, and dyslipidemia in epidemiology as relevant risk factors, but not the history of nephrolithiasis or onychomycosis. Again, it's not that you will lose this information. You will keep track of it in a different aspect of the case presentation or write-up. What you don't want to do, though, is clutter up your brain at the outset of a patient illness script presentation with information that isn't absolutely important to the assessment of the patient's clinical complaints. Time course is a little bit easier, and I think you're feeling very comfortable with this based on the results from the homework that we saw. But you do include a statement about the duration of the symptoms, how long it's been going on, when was the first time that you saw, and again, we'll talk about how we process that. And you also should include a descriptor of the symptoms' persistence and intensity. And be attentive to this, because it often does make a difference if it's been steadily progressive, waxing and waning, episodic, or some other descriptor of inconstancy of the quality of the symptom. Now, what about the syndrome statement, the classic signs and the symptoms? This is perhaps the most challenging aspect of the patient's illness script construction when we begin to consider what do we include and what don't we include. Importantly, we start with elements that are not already included in the epidemiology and time course. So you've already done that. You don't have to worry about that anymore. The first thing I recommend people do as they begin to construct this is to exclude any non-specific markers of illness. Anything that just occurs because someone is sick. And typical descriptors we'll see are things like fatigue, malaise, mild tachycardia that's proportionate to another physiologic derangement, meaning a heart rate that's mildly elevated in the setting of somebody with a high fever. The tachycardia doesn't add anything to the presence of the fever. Also, don't include past medical history that's not linked in some way to the chief complaint. And don't include prior diagnoses for this chief complaint unless they were unequivocally correct. One of the cases that we'll review includes a description by the patient of other diagnoses given to her by past physicians that didn't seem to be right. And so in general, as you see a new patient, it's best to start from scratch to avoid confirmation bias, which is a common form of bias leading to diagnostic medical error. Now, judgment is quite present here, too, as we're deciding what to include in the syndrome statement. And it does sometimes require a leap of faith and then continuous reflection on whether that made sense when you ultimately find out what was the cause of the patient's symptoms in front of you. So let's give a couple of examples. Tachycardia. If it would cause problems in its own right, rather than just be a marker of another more specific derangement, you could include it. So this tends to be at the extreme. So a heart rate of 180 is always relevant as an independent component of the problem representation or patient illness script, because 180 is high enough to be a problem in its own right. On the other hand, 110 or 112, particularly if associated with another symptom that's much more dramatic, like severe pain or high fever, would generally not merit inclusion. And as we talked about earlier, our goal is to get rid of all but the most precise elements in the patient's presentation so we can really attend to them with our full working memory. Fatigue and malaise are rarely diagnostically specific. It's important if you hear them from your patient, especially if they talk about them a lot, to look for a better descriptor of the problem. So for example, when you're talking about fatigue, ask the patient what activity can't they do? Is it that they can't walk up a flight of stairs, or they can't lift their arms to brush their hair, or they can't walk a block? This may clue you in to a more precise neurologic phenomena than just overall fatigue related to illness. And then finally, truly transient symptoms. Oftentimes, patients who are significantly ill will have an experience of multiple physiologic derangements. And at times, we'll go chasing after many different elements when in fact they were very short-lived. So be careful with over-extrapolating transient symptoms to a more significant problem. One loose stool does not diarrhea make. So let's look at Sophia's case again and examine the difference between a simple problem list and a processed problem list, and then we'll move from a processed problem list to the patient illness script. Sophia's history has been well recounted in this course, and typically as novices are listening to a presentation of a patient like this, they will begin to keep track of a problem list, and we'll ask you to do this in a minute with Mrs. Garcia as we move to another case. And what you'll see from their problem list is it's really a linear tabulation of the oral presentation that was given. So you can almost track it. So for instance, these first elements, leg pain, can't walk, feverish, funny spots, red warm ankle, those are all elements of the history that she gave us. And then we see swollen Achilles tendon, history of elbow pain, temperature, fatigue, sarcopenia, sexually active. A long list of things. Almost none of this is processed. In fact, I would argue nothing of this is processed. It's just a simple problem list. And we have gotten more than our 7 plus or minus 3, right? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Ooh, just barely. But let's see what we can do to make this a little bit more precise and sophisticated by processing the way in which we've learned to process. So we take feverish and a temperature of 101, and we say that she has fever. Or we could argue that we could use the term febrile if we wanted to. This is really interesting to me when I analyze the performance of novices versus experts. We see this a lot, that as people are keeping track, they don't even sort of combine things that are clearly redundant, like feverish and temperature of 101. Then we're going to list as problem number 2, oligoarthritis. And we're going to say that because we have ankle and wrist, so more than one, and it's red and it's warm, so it's not arthralgia. So that's a nice descriptive term, and this again highlights the value of processing. One term has gotten rid of 4 words, and probably this history of elbow pain as well. Then enthesopathy, and you get 14 points if you know what enthesopathy is, but it means a tendon disorder. And here we have this swollen Achilles tendon, right? Much more precise and easy to communicate to a rheumatologist if you're going to call them. Distal discrete hemorrhagic papules, that is just a much more precise way of describing her funny spots, gives us a lot more diagnostic specificity. And then we have what I would consider to be her exposures. She's sexually active and has exposure to ticks, so that's very relevant to complaints of joint pain. But her history of well-controlled asthma is important for us to understand because asthma is a chronic condition that requires treatment, but it is not anything that is necessarily related to a chief complaint relevant to arthritis. So that's our problem process list, and we're going to carry that forward to the next page. So now we're going to talk about moving from the processed problem list to the patient illness script. Now, this may in many ways, for those of you who are experts, feel like an academic exercise. But in fact, in terms of activating memory stores, it is much easier for us to activate our disease-based illness scripts if the patient's problem representation looks like a patient illness script. It's easier to compare and contrast. You see element to element, and this turns out to be a very useful tool. So let's look at what this looks like. Again, the exposures, the elements that we need to pay attention to are epidemiology, time course, syndrome statement, and then other history not immediately relevant to the chief complaint at hand. So you see what we did is we took sexually active and exposure to ticks and her age and put it in epidemiology. This is a young, sexually active woman who's had exposure to ticks. Remember, she was a camper. The time course is acute and evanescent. Came and went. Her elbow came and went. Her wrist has gotten steadily worse. And the syndrome, febrile, oligoarthritis, and enthesopathy with discrete hemorrhagic pustules. That's our patient illness script. And you can begin to see how much that looks like a disease-based illness script. So where do we go from there? Well, those of you who are third year or fourth year students recognize that a common challenge attendings give to young learners is to ask them to summarize that case in one sentence. And the patient illness script is the foundation of that case summary. So if you're asked to do that, these are the elements you need to include. Epidemiology: who is this patient? A 17-year-old sexually active woman with a history of tick exposure who presents with an acute history of evanescent oligoarthritis and hemorrhagic pustular rash. She also has a history of asthma. So this is the one sentence. We took that entire long case presentation and have now boiled it down into a very rich, distilled problem representation that any physician listening on the phone could accurately diagnose once they've gotten beyond their training. So quiz 3.1. Every patient's illness script should include a statement about the patient's race, weight, symptom complex, or vital signs. And the answer is symptom complex. Vital signs would be incorporated into that symptom complex. And as we talked about, race as a social construct can be problematic, along with weight, as potential biasing in a way that's not helpful to the problem representation or the ultimate differential diagnosis. So today we're going to do something a little different, and as you're listening, I ask that you take out a piece of paper and a pen or open a new screen on your computer. And as I present the next case, I'd like you to write a problem list along with me and use as much as possible process terms if you feel comfortable doing so. And then we'll move from a typical list into a more processed list. But I'd like you to see how this feels as you're keeping track of a case that you might hear on rounds if you were working in a hospital or in an emergency room. Are you ready? Great, let's go. Ana Garcia. Ana Garcia has a chief complaint of "I'm short of breath." And she's coming to us because this has been going on for a month and she's already seen 2 physicians and they weren't able to help her with the diagnosis and treatment that they arrived at. She's 57 years old and this is her history. 1 month ago, she noted several spells of shortness of breath and a dry cough. The spells would come on abruptly and then would abate after about 30 minutes. She was seen in an emergency department where she was given an albuterol inhaler for asthma. She noted no improvement. The following week, she had a severe episode of shortness of breath at work without provocation. It lasted about 45 minutes and then went away spontaneously. She was then seen by her primary care provider, who thought her symptoms were compatible with panic attacks, advised her to stop caffeine and smoking and to try stress reduction. Over the past week, however, her shortness of breath has become constant to the point where any activity leaves her gasping for breath. She denies orthopnea or paroxysmal nocturnal dyspnea, but she does note that she's more comfortable laying on her left side. She continues to have an irritating dry cough and mild right-sided chest discomfort that does not increase with breathing. So let's add some more information about Ana to your problem list. She admits to a 30-pound unintentional weight loss over the past month. She notes pain in both calves after walking about 1 block, relieved by rest. She has no fever, chills, night sweats, hemoptysis, or purulent sputum. And she's had no recent travel, sick contacts, or exposure to pets or toxins. She denies joint aches and pains, skin rash, or loss of hair. She has had hypertension for 6 years, and she takes Zestril 20 milligrams a day and hydrochlorothiazide 25 milligrams per day. She has a 30-pack year smoking history and no injection drug use. She manages McDonald's as her occupation and has for a long time, and she has no known drug allergies. I'll give you a minute to catch up. Her physical exam reveals a blood pressure of 130/76, a heart rate of 110, a respiratory rate of 28, temperature of 98.9, and a pulse oximetry of 99% on room air. She's mildly dyspneic at rest, but is able to complete full sentences without pausing. Her head, eye, ears, nose, and throat exam is normal. Her neck exam shows a right supraclavicular firm node about 1 centimeter in diameter. Lungs show dullness to percussion about 3/4 of the way up on the right. There are decreased breath sounds, decreased tactile fremitus in the same area. There is no agophony, no wheezing or rubs noted, and the left lung field is clear with normal breath sounds. Cardiovascular exam shows a normal jugular venous pulsation and a normal PMI. Her heart sounds are normal with no extra sounds noted. She does have diminished dorsalis pedis pulses bilaterally, but no bruits are audible or present. Her abdomen is normal with no hepatosplenomegaly. Her extremities show a loss of hair on her distal shins, but no clubbing, cyanosis, or edema. Neurologic exam, joint exam, and skin and hair exam are all normal. So this is a simple problem list done by one of the novices that we have worked with in the past. And again, as you see, it is a linear representation of the fairly complex history that I just recounted. And defying the limits of human attention has 18 elements for us to keep track of, ranging from shortness of breath to 4 weeks, to tachypnea, and multiple elements of an abnormal physical exam. So our goal with the process problem list is to make this list more manageable, more precise, and more useful to us so that we can then move from the processed problem list to a patient illness script and on to our differential diagnosis. So let's look and see how this works. We start off with her descriptor. She's a 57-year-old woman. We're not convinced that her hypertension is relevant to her presentation, but we're going to keep it on the list down here. The first thing we're going to do is we're going to get rid of things that are unsubstantiated. So her recent diagnosis of asthma because of this chief complaint that didn't get better with asthma treatment, and panic attacks that didn't get better with panic attack treatment, are crossed off the list as being irrelevant and something we don't have to pay attention to anymore. Furthermore, we're going to make the leap that tachycardia of 110 is probably not an independent marker of illness. It's a nonspecific marker of whatever else is going on with her, particularly around her dyspnea. We think her smoking history is relevant, and we're going to work on processing her chief complaint. So we take shortness of breath for 4 weeks. We take dyspnea at rest, and we call this subacute progressive dyspnea, importantly without hypoxia. That's kind of interesting and may have been what led the primary care provider and the emergency department physician to diagnose her with asthma or panic attacks, which typically aren't associated with any hypoxia. But this may be helpful mechanistically as we begin to compare different differential diagnoses. So we got rid of that. We got rid of the dyspnea at rest. And the tachypnea is represented by the dyspnea, so we don't have to include that any further. She has non-productive cough. And then she has right-sided what I would process as visceral pain. Now, pain has lots of different qualities, and pain that's constant and heavy, as she described, we would generally describe as visceral pain, and contrast to colicky pain, which waxes and wanes, ischemic pain, which is often described as pain out of proportion to the physical finding. So we're going to call this right-sided visceral chest pain. And it's clearly non-anginal would be the other descriptor that we contrast this to. 30-pound weight loss. She did not try to lose weight. She told you she didn't try to lose weight. And so I would process that as pathologic weight loss to make sure that we pay attention to that symptom. It's going to be helpful to us, I think. So we want to make sure that we don't just include it in a list of nonspecific symptoms. And then this neck node, this is fascinating, this neck node over here, this right supraclavicular, actually not neck, it's supraclavicular, but it was found during the neck exam. This also is a pathologic node. Why is it pathologic? Because it's fixed and firm, and it's in a place where you shouldn't be able to palpate a node. So immediately, rather than just describing a node, we're going to say it's a pathologic node. And we're going to describe it as adenopathy, so that's an abnormal node. And we're going to use the descriptor regional because it's in an area located close to her chief complaint and isn't associated with lymph nodes anyplace else. Rather than diffuse or lymphadenopathy, we're going to say it's regional adenopathy. So we've taken care of that. We've taken care of the 30-pound weight loss. She has complaints of leg pain with walking, relieved by rest, decreased pulses in her dorsalis pedis, and loss of hair in her distal shins. That's enough for us to combine those three symptoms into a diagnosis of vascular claudication. We don't know why she has that, but calling it vascular claudication, again, is much more specific than talking about leg pain with walking. Now, I'm going to erase all of my marks here just to give me a little bit more space on the page, because the next element talks about how we interpret the physical exam. I believe that her physical exam can be interpreted as evidence of pleural effusion, but this requires physical diagnostic expertise. And what we realize is she's got dullness to percussion in the right lung field. That means there is something between the lung, which is normally full of air and resonant to percussion, and the chest wall where we're percussing. So that could be fluid, and the question is the fluid within the lung or outside the lung? The fact that her tactile fremitus is down suggests that it's outside of the lung rather than in a consolidated focus within the lung. And that's also compatible with this decreased breath sounds in the right lung. If you had pneumonia as the cause of the dullness to percussion, you would expect to hear increased breath sounds because fluid within the lung transmits sound better than air does. So these three phenomena, dullness to percussion to the right lung, decreased breath sounds, and decreased tactile fremitus, knowing our physical diagnostic interpretation can allow us to say that she has physical exam evidence of a pleural effusion. So here's where sort of using all of the basic science you learned in the first year or two of medical school begins to help you with processing over and above just translating a symptom into a more precise medical language. And so with that, including her history of hypertension, we've moved to 1, 2, 3, 4, 5, 6, 7, 8, 9. That's well within the 7 plus or minus 3 we wanted to. And we've gotten rid of nonspecific symptoms and symptoms that were non-substantiated. Good. Where do we go from now? So we take that process problem list and we put it into a patient illness script so that it looks a lot like the disease illness scripts that are already in our brain that might be relevant to this patient's chief complaint. And we use our 4 statements: epidemiology, time course, syndrome, classic signs and symptoms, and for the patient illness script, other history. So the epidemiology, this is a 57-year-old woman with a minor smoking history. It's interesting. Her smoking history is 30 pack years. It's not huge, but it's really compelling in the setting of what looks to be a lung problem. The time course of her clinical presentation is subacute. It's been going on for 1 month, right? And it's been progressive. It started off as episodic, but now it's constant and worse. And the syndrome statement, this is a woman who's developed subacute progressive constant dyspnea and cough with physical exam evidence of a pleural effusion, pathologic regional adenopathy, and pathologic weight loss. Are you beginning in your mind to say, uh-oh, there's a problem here? And it's much more robust a problem representation than the physicians who diagnosed her with asthma or panic disorder put together. And it may be because the symptoms evolved, or maybe because you've been working hard to be precise about defining the patient's illness script before you launch into a differential diagnosis and avoiding some of the biases that might occur if you just start with a single symptom. Our other history is hypertension and vascular claudication. And we've put those there because they're not clearly linked to a major lung complaint, especially in someone whose blood pressure appears to be relatively well controlled. So let's take this illness script and think a little bit more about how it looks like the disease-based illness script. Well, the only thing missing in the patient illness script typically is a comment about the mechanism of disease. And that's because we're talking about a patient, right? Rather than the disease-based illness script, which is talking about the disease. But even within a patient's representation, there might be mechanistic issues that arise that help you be more precise in the way you define the patient's symptoms. For example, this patient has really substantial dyspnea, but her pulse oximetry suggests that she's not substantially hypoxic. She might be a little bit hypoxic, but her pulse ox is normal and her dyspnea is profound. So one of the questions to ask yourself is that a clue that's useful to us? Are there mechanisms of dyspnea without hypoxia that would help us be precise in the way in which we evaluate this patient's symptoms? And again, go back to your first and second year of medical school when you learn basic science, and you can see how relevant this is to the establishment of a good diagnosis. So, quick physiology review. As we talked about, patient illness script can include proposed mechanisms of disease to increase specificity. And let's look at dyspnea. And remember that dyspnea is a very complex sensation. It's manifested and modulated through 3 different, at least, types of receptors. Chemoreceptors in the carotid body or in the medulla that respond to hypoxia, hypercapnia, and acidosis. So hypoxia doesn't appear to be present in our patient. We don't know about hypercapnia or acidosis until we look at her labs. But clearly this is not the case. But it does also respond to mechanoreceptors in the lungs, which can be related to abnormal problems with lung inflation, either bronchospasm, interstitial edema, or problems with stress receptors. So this is beginning to make us think that maybe the problem that Mrs. Garcia has is not one of hypoxia or metabolic issues, but one of a mechanical problem that's interfering with her ability to inflate, expand, or stretch her lungs. And so that would be compatible with our physical exam finding of probably a pleural effusion as opposed to diffuse interstitial lung disease that's interfering with oxygenation. And the third type of receptor is a metaboreceptor related to the muscles in the lung environment that get stressed during exercise. But we know her dyspnea occurs at rest as well as with exercise. So this is probably where our focus should be. And again, this may not be necessary to help you with your patient illness script in this case, but it is an interesting observation that even patients' mechanisms of disease might help you understand what possible etiologies are causing the problem that they're presenting with. So, quiz 3.2. In Mrs. Garcia's case, we dropped the sign of tachycardia from the ultimate process problem list and patient illness script because, number 1, we questioned whether the value was correct. Perhaps the person who took the vital signs didn't measure it correctly. Number 2, it didn't really count as tachycardia. Or number 3, it was a nonspecific marker of illness. And the answer is number 3. It was a nonspecific marker of illness. Didn't add to the other information that was already present and more impressive, and we wanted to get rid of facts that weren't helpful to us so we could attend to the most important facts.